And it's a real honor to speak with you guys today. And thanks, Oscar and Andre, for the invitation. I'm going to be talking about what I've learned in last 21 years in cervical osteotomy, and my disclosures, none of which are really significant for this talk. During my 21 years of my career, the amount of cervical deformity surgery compared to degen surgery has dramatically increased. Some of this is due to iatrogenic deformity, and then some, as Andre had mentioned, is due to an increased appreciation for the importance of reestablishing normal alignment. Because of all this, we're doing a lot more osteotomies to try to restore alignment, and many more long construct surgeries to try to assure that that alignment will be maintained. Also, during my career, we've seen an increase, at least in the United States, of the comorbidities in this population. They've gotten older, their bone is weaker, and the demographics has really changed quite a bit. As part of the International Spine Study Group, we published a classification for cervical osteotomy. This was not meant to be prescriptive to tell surgeons what to do. It was really meant much more around trying to develop a common language of what we were talking about so we could compare complications, realignment rates, and really do comparisons between different types of realignment strategies. And I'll be talking mostly about type 2, type 4, and then type 6 today, which are really, in my practice, the workhorse of what we're doing. I thought it would be interesting to also just show you in my career what's really changed. When I started in cervical deformity surgery, the initial cases, what we all thought of as deformity, they were really ankylosing spondylitis cases, and maybe occasionally a post-laminectomy kyphosis. It's one of our original cases back in 2002 that I did when I first started at UCSF. And I staged this, did 2 different osteotomies, one an opening wedge, which I don't do that much anymore, and then a VCR later in a staged fashion. This is a much more recent case. A lot of our osteotomies these days to restore cervical alignment are to treat iatrogenic deformity. And this, we did multiple osteotomies in one sitting for this patient because we now use 2 surgeons for a lot of these cases. So now to go through some basic tips on planning and assessment, which is probably equally important to execution. And then I'll go over the execution in a moment. So the definition of the apex location is really important because it's going to be where you place your osteotomy. So in patients that have low C2 slope and high T1 slope, as Andre talked about, these patients usually require osteotomy in the upper thoracic spine or even mid-thoracic spine because that's where the apex of their deformity is. In patients that have high C2 slope and a low T1 slope, these are the patients that are often getting posterior column osteotomies in the mid-cervical spine because these are isolated cervical type deformities. So this is really where we do our type 2s and our type 4 osteotomies, which I'll show you. And then a lot of times, unfortunately, life is more complicated, as we all know, and there are mixed picture deformities where there's high C2 and high T1 slope, and these often require different strategies.
Put your neck in a
We also
comfortable
assess
position.
patients standing in supine to determine the rigidity of their alignment. Flexion extension films don't work very well not to do this because there's no stress on the patient to see whether they can relax. This is very important in preoperatively deciding whether you need, for example, an anterior posterior approach and whether you're going to be able to get these corrected without a 3-column osteotomy. For mid-cervical fixed deformity, we usually use a 540 approach, combining type 2 osteotomies posteriorly with type 4 osteotomies in the front. And I'll show you, this is the graphical depiction of the case. We do the type 2 in the back. This is from an actual case. And then we use Penfield 4 to protect the vertebral artery laterally. And we come all the way out with the drill to the Penfield 4, and then come around even through the uncovertebral joint with a Kerrison, again, protecting that vertebral artery. It's not necessary in most cases to visualize that artery unless you're going to do a cervical vertebral column resection, where then we get the artery out. This is much like you would do in a spondylectomy type procedure where you're going to get both arteries out, take off the transverse processes, something like that. But for most cases, you can kind of break it open once you thin it or come around a little bit the uncovertebral joint with a Kerrison, and you get this kind of segmental mobility even through a prior fusion mass. And here you can see again the demonstration of the mobility, previously completely rigid segment. And then to do the correction, we overbend the plate and we pull the spine up to the plate. So we start at the end and work our way to the middle. And again, we don't want to oversize the grafts because if you make it too rigid, it won't pull up. But this is the technique to restore lordosis from an anterior approach. And here's a case example of that. A very important point in planning, especially 3-column osteotomies, is in determining the position of comfort. And the reason this is really important is, just like in thoracolumbar deformity, you don't want to correct the patient with a still compensated hyperextended pelvis. In the cervical deformity cases, you don't want to correct these patients where they still have occipital cervical hyperlordosis. So we ask the patients for the x-rays to assume a comfortable position. And normally what happens is they relax the occiput to C2 region. And you can see what happens to the size of the osteotomy. It really dramatically increases. And this way, you know, if you accomplish this size of osteotomy, you're going to have that patient fully corrected, but also with relaxed compensation, which is very important to their ultimate, postoperative result. Another important pearl I've learned in my 21 years is to try to avoid PSO when possible. And many times type 2 osteotomies, especially when combined with pedicle screws, can be very effective. In comparing the two types of procedures, type 2 osteotomies result in better cervical lordosis correction. PSOs result in better translational correction. Some of this is due to how they're used and where they're used. And the PSO is usually done at the base of the neck or in the upper back, whereas SPO is usually done for the mid part of the cervical spine, so it's not surprising. But importantly, SPOs have about 10% lower major complication rates than PSOs, so if you can avoid it, it's important. Also, we've been using a lot more pedicle screws in all posterior approaches rather than combined anterior-posterior approaches because the medical complication rate is much higher when we use combined approaches. So here's an example of an all posterior approach with a semi-rigid deformity. We use type 2 osteotomies for this case. And the most important part of avoiding complication in type 2 osteotomy is removing this superior facet fragment. It's often hiding underneath kind of the residual lateral mass, and you have to tease that out with an angled up curette before you close it down. Otherwise, you're going to get iatrogenic foraminal stenosis. Another nice tip sometimes is to, if you are going to be able to go anteriorly, to build the patient up a little bit in the front before you close them in the back with a cage, and that also prevents iatrogenic foraminal stenosis. And then this is how we do it. We kind of gradually work our way down. We lift the head up. We apply a bit of a cantilever. We lift the head up a little more. We use a little more cantilever. We don't use all cantilever because I like to use the head because it decreases the stress on the instrumentation. So I like to move the head during the corrections. And you can see we use all pedicle screws now on the vast majority of our deformities. We now use mostly custom rods to make sure the realignments are as accurate as possible. And I'll show you a case example of that. This patient has anterior translational deformity with the external auditory canal anterior to the chest. Very thick patient, as you can see. He was a PJF, a patient after a prior AIS fusion. Very common indication these days for cervical thoracic osteotomy. And we planned his rod and then executed him using the planned rod and got a very nice matched result to the preoperative plan. When you're using custom rods, a very important part of using custom rods to assure adequate alignment is to not use your custom rod as a correction rod. So if you're going to use cantilever correction forces to close the osteotomies and to get full correction, you really want to use a correction rod, because then the custom rod should just lay in. If you're bending that pre-ordered custom rod, then it's not at the actual optimal post-op alignment. So we do a correction rod, and then we use our custom rod as a template to make sure we've gotten adequate correction. A very important point is to try to use pedicle screws when at all possible. This has been just like full control of the vertebral artery, as Oscar described, is really disruptive and transformational in what you can do in the cervical spine. the use of pedicle screws is also disruptive and transformational in what you can accomplish with cervical corrections as well. And I'll show you a couple case examples of that. Here's a patient where it was simply impossible to get in anteriorly. She was completely rigid. There was no space available between her chin and her chest. And we literally broke her open using type 2 osteotomies and basically created an opening wedge using all pedicle screws. We just broke her fusion mass using the pedicle screws. And then she ended up needing 2 PSOs in the lumbar spine for her optimal realignment. And she was wheelchair bound at baseline, but was looking for a better alignment in the wheelchair. Many times, again, you can avoid PSOs by using type 2s. Here's a case where we use pedicle screws and type 2s for cervical thoracic scoliosis, another not uncommon indication. Patient has a relatively rigid curve. Most of these upper thoracic curves, unlike mid-thoracic, are rigid, especially in adults. And so you need to do a nice PCO release and then pedicle screws to do it. And I'll just show you the mechanics of the moving the head to do the correction. So my partner's putting on the reduction towers. I'm controlling the head. And then when he tells me he has the reduction towers ready to go, I'm going to slide the head over. And that's going to be the maneuver in this case to get the correction. So you can see me now moving the head over. So it's not just a translational posterior move to get correction, but you can also correct scoliosis in the cervical thoracic spine by moving the head laterally. And here's his result. We use navigation to place the screws, and importantly, we follow the navigation on the screw itself. So to assure optimal accuracy, we'll literally navigate the screw going in to make sure we're not breaking laterally into the foramen transversarium. The mechanics of 3 columns. This is very similar to the thoracolumbar spine with one exception. We like to use conical taps to do the decancellation. We developed these years and years ago to make it safer than using a high-speed burr around the nerve roots in C8, T1. And then we break the lateral border of the vertebral body, and then we do essential impaction. I'll show you this. That was from JNS Spine if you have an interest in looking at the original paper. We use racks to stabilize the spine. Here you can see the decancellation, the conical tap going in. And then after the conical tap is utilized, we'll then bring in a box chisel to finish that up. And this is the box chisel. So you use the conical tap to mostly do the decancellation, and then you'll just clean that up with the box chisel. It's very quick, especially in the upper thoracic or cervical area. It's pretty small vertebral bodies, and the 3-column osteotomies don't take very long to accomplish. We use racks, as I mentioned, for stabilization of the osteotomies. You'll see that in all our cases. We haven't used temporary rods in years. We use only racks. And then the central impaction to break the middle column. We used an osteotomy set that has this type of central impactor to do that. And then we correct and close the osteotomies using head manipulation. And when my partner tells me we're ready, I'll lift the head up to do the correction. This was a C7 PSO we were closing by head manipulation. This is a very nice device. I don't have anything to do with this company, but it's essentially power steering for osteotomy closure. It's an OSI Mitsuho product. And you just literally touch 2 buttons, and the head is like under power steering. It's actually a hydraulic lift. So you're not having to strain very much to change the head position during the operation. It's very helpful. Assessment on the table of adequacy of correction we do by placing a hand on the back of the head and making sure that it's level to the thoracic apex. If the table is level and the back of the head is level to the thoracic apex, that usually means your osteotomy has been sufficient and you've achieved an adequate correction of the cervical spine. We also do in-construct measurement, where we're looking at various parameters for this right now with a C2 to the vertical angle to our LIV as well, to try to figure out what's going to happen below the level of the instrumentation post-op. Because as I'll mention at the end, DJK and DJF is still a big problem. Another pearl is don't skimp on what you need to do. This is a fixed deformity from a prior PJF extension. This patient had AIS surgery and then extension for PJF. You can see they didn't correct her T1 slope at all. and she's still very translated. This was a young patient, and we're thinking, gosh, we really don't want to subject this young patient to a risk of a 3-column osteotomy, but there's no other way to correct this deformity. So we did a 3-column osteotomy in her to get her corrected. We put in supplementary rods, and then her pedicles were too small to instrument, so we did ACDF to fill her in the front. Again, in very severe deformity, we don't skimp anymore in our corrections. We use 2 surgeons to do these cases. So this is a case where we did 2 upper thoracic PSOs in the same sitting, and then a lumbar PSO to get her final correction. So this patient was requiring 3-column osteotomies to get her fully corrected. I think the only way to really do this safely is with 2 attending surgery, and we can talk about that at the end if you guys wish. We've adopted that for all of our complex procedures here at UCSF. Problems and complications, they are many in this type of surgery. Junctional failure is probably our biggest problem right now. We do have reoperation. Most common indication for reoperation is junctional failure. And another problem in these cases is C8 palsy. We now try to avoid C7 and T1 osteotomies when at all possible, and move our osteotomies lower to T2, T3, T4, because at 1-year follow-up, if you have a C8 palsy around the time of surgery, about 28% were unchanged. Doesn't get better like a quadricep weakness in a lumbar PSO. This is my 3-column series, 151 cases, and you can see we've really been using these lower osteotomies much more. The upper osteotomies at C7 and T1 were from much earlier in our experience, and we switched to avoid deficit. DJK and DJF still a big problem for us. We've gone lower now. We usually go below the thoracic apex, but even then, we end up extending a proportion of these patients to the pelvis because of distal failure. PJF is not a big problem, especially if you use pedicle screws, but DJF remains a significant issue. And then finally, rod fracture, also a problem in the cervical thoracic junction. So now we use this crossing Z-rod. We haven't had any rod fracture since we started doing this. We use a W connector and then a crossing rod. It's another 5-5 rod. It protects the spinal cord, it provides rotational stability, and it prevents rod fracture. So thank you, you all very much. And it was really a great honor to participate with my friends.
Thank you, Christopher, and for perfect presentation with very, very difficult cases. And is there any questions? Yes.
Please, I would like to ask you a question. It has to be a question on vertebral artery, of course. Some of these maneuvers, sometimes you can risk damaging the vertebral artery, these reduction maneuvers. What are the cases specifically that you try to expose and skeletonize the vertebral artery to be on the safe side?
Yeah, I would say we do that in cases, as I mentioned, where we're really resecting all the bone, like if it's a very robust fusion mass, or if the patient, for example, has really a dominant circulation on one side or some type of vascular abnormality, like you mentioned in your cases, where we really want to make sure we didn't damage it, or maybe a very calcified artery that we want to try to avoid any type of really significant manipulation. The other thing I do a lot of is primary tumor surgery, and in all tumors, we get the artery out, obviously, when we're going to try to do a en bloc resection. But I would say over the years, Oscar, we've become a little less aggressive in getting the artery out for deformities. And many times we can kind of crack it open, crack open the residual fusion without really getting that artery totally visualized, except in rare cases. So we'll thin the bone, get it very thin, and then use a small cob in the disc space to break it open and mobilize it. And usually that's enough. And I haven't seen issues with strokes, in that patient population, unless there's some, arterial, open arterial damage, or, at the time of surgery or something like that. So I haven't seen that. It's a concern for sure. But I'd be interested in, your experience with that as well.
Chris, I'm not a big deformity surgeon, so that was why I was asking you this question. Certainly, as you mentioned, for tumors, for even for neurinomas, I try to do it from the front, get the control of the vertebral artery. Sometimes vertebral artery is in front of the tumor, sometimes it's behind. So you really want to have your enemy under control since the beginning of the surgery. But I'm not a big deformity surgeon as you are, so I cannot say anything. But in tumor surgery, of course, you need to control the vertebral artery.
Dear Chris, it was a really very nice talk. There are mainly two concerns that somebody believe that if you make too much correction in the mid-cervical levels, you can get vertebral artery kinking. Are you scared of that?
I am, and I was, but I'll be honest, I haven't seen that. And I've seen just about every complication you can imagine, unfortunately, but I have not seen that complication from kinking. Now, I would say that, I think I have one C5 PSO and maybe two C6 PSOs. We're not doing a lot of PSOs in the mid cervical, unless we're really forced. We're usually doing vertebral column resections there, where we resect all the anterior bone, all the posterior bone to do the correction. But I haven't seen that complication.
Yeah,
Maybe we've just been lucky.
What about the during positioning of the patient from a posterior approach? Do you keep the head in the Mayfield cramp or under traction?
Yeah, good question. My bias, and I know there's another, Dan Rue is a really good deformity surgeon, likes to use traction. My bias is to use fixed head. So I use a halo ring, and I use it in the mobile OSI attachment. So if I'm doing, I use a lot of chisels and things to do my corrections. I like the head to be totally stable. And then I like to be able to do a little correction, take a little more bone, maybe put a little more cantilever, move the head a little bit more. I personally don't like the head moving around as it does in some of the traction. So I use a fixed head, but not a Mayfield. I use a halo ring at the time of surgery.
Good. What about the level of the lower level? I do some cervical deformities and I do more distal junctional failure, as you have mentioned. How much should we go down? What is the key point for that?
Oh, that's really difficult. When I started doing cervical thoracic PSO, if we were doing a C7 T1 PSO, we used to stop around T5. But we found stopping short of the thoracic apex really caused a lot of distal failure. So then we started going lower. Just like when you go higher in TL deformity, you see less failure, but not zero failure. And so the unfortunate part is when they fail after you go below the thoracic apex, then in an older patient, usually the next place to stop is the pelvis. In big corrections, patients with softer bone, we're definitely going lower. And maybe this will sound totally crazy to the audience, but I just want to say that this is.
Do you mean with lower? Lower is T9 or lower than this?
T10
or lower than
T10
this?
or the first lordotic level, like a Schurman's case.
Okay.
So sometimes even L2. If L1-2 is the first lordotic level.
Really, that much?
And I was just going to mention, in some patients that have a lot of degenerative arthritis in the lumbar spine and who really have significant deformities, we will do upfront C2 to the pelvis on those patients. And that might sound crazy, but those patients are some of the happier patients because they don't have any failure and they might be stiff, but they're not breaking down their distal segments. And I know that sounds really crazy and super aggressive, but in some of the older population, that seems to be the most durable operation sometimes.
And
Thanks a lot. Great talk.
Yeah, may I ask you a
Um,
question?
yes, okay.
Chris, thank you so much for this really good presentation. I have two questions. At the beginning of the sagittal balance, we have started with the difference between pelvic incidence and lumbar lordosis in time. We have seen some papers. It's changed according to the age. Is there new papers, or do you have any experience about? We know that we have to get a proper cervical lordosis, cervical sagittal alignment according to the difference between T1 slope and cervical lordosis, C2, C7, SVA. Do we have any experience about related with the age, the cervical sagittal balance?
Yeah, it's a good question, and unfortunately, the answer is like 30 minutes long. But I'll just say that the age association that we originally thought was so critical in thoracolumbar alignment seems to be going away, because what we were measuring when we published those age-associated papers was really the degenerative process itself. And if you measure those patients out, actually that don't have any arthritis, they have the same sagittal parameters as patients that were younger. So we've gone away from that now in the thoracolumbar spine. There's a great paper called Means, MEANS, that goes over a lot of that. So we don't believe it really in the cervical spine. We do know that older patients probably need the ability to, as their balance deteriorates, to be able to look down more. So the only thing that I've really changed in my older patients is I've used more pedicle screws and tried to leave more of their upper cervical spine open so they can look down. Because younger patients really have much better balance. They want to be perfectly aligned. The older patient, we try to preserve as much upper motion as possible. Their swallowing's also usually not as good. But no, we use the same parameters in older patients basically as younger patients. I don't think that's going to pan out. Just like it seems, we initially published it in thoracolumbar and then kind of retracting it. I don't think we're going to go down that road in the cervical thoracic spine.
And for the custom-made rods, you made the necessary measurements and you decided the level or the type of the osteotomy according to the deformity. Then what's the issue of the rod? Is that the upper part is thin than the lower part, or are you using longer screw heads that is passing to 5.5 or 6? If you use the dominoes, you're using it, but is the property of the custom-made rods, is the upper part thin and the lower part thicker, or?
Yes,
Did you get the question?
the upper part for the cervical thoracic rods, the upper rod is 3.5 cobalt, and the bottom rod is 5.0 or 6.0, or 5.5 or 6.0 cobalt. And we plan them, and then as I mentioned, that rod we use only to drop in. We don't do any correction force application on that rod. It basically tells us that we've gotten our alignment what we wanted. And a lot of times when we try to drop it in, if the correction is not adequate, it tells us we have to do more correction. So we like it for that reason. I do think cervical thoracic realignment is even more complicated than thoracolumbar because everything below it is usually still moving. So it just makes it all that more complicated. And the rods do include the ability to predict reciprocal changes. So they've included the reciprocal change prediction in the rod. I don't think it's totally there yet. It's completely accurate in reciprocal changes, but I believe by committing to that data acquisition, that once we have 1,000, 2,000 cervical deformity patients, we'll all be better because we'll have all that reciprocal change data that we know is going to go on. And that, to Mehmet's point, is probably going to be how we prevent more of the distal junctional failure. I think understanding what's going on in those distal unfused segments is very hard right now.
Chris, please come to Turkey if you're available for our next symposium or in our meetings. Please tell our friends that the pre-bending rods or the custom mates are useful things, because it's difficult to give these lectures in Turkey and to tell this is necessary. The custom mates are very useful things in our deformity surgeries. We will invite you. I hope you will be available to come to Turkey.
I'd be happy to. Thanks so much for the
Yeah.
invitation. I'm honored.
Yeah.
And Andre Joachim wanted to ask a question. Andre?
Hi, Dr. Ames. Very nice presentation, as always. I would like to ask you about stage procedures. You say that today you do with 2 surgeons most of the procedures because most of these patients are old and fragile. I would like to know about you when it's possible. Do you recommend or do you use to stage the procedures or do same-day procedures as a rule?
Yeah, it's a great question. I mean, 95 or 90%, I would say 90% of our procedures are now unstaged using 2 surgeons. So we can do everything, including, as I mentioned, what you guys I'm sure think is crazy about C2 to pelvis. We do those procedures all single stage. We won't do 3 3-column osteotomies. 2 3-column osteotomies is our max, even with 2 surgeons. So if we have to do 3, like if the patient needs 2 upper thoracic PSOs and a lumbar PSO, we don't do that in the same day. And we also have a low threshold to say that's enough for today, and come back, a few days later. So
how do you stage? How long?
well, if everything goes perfectly and the patient's hemodynamically stable, we'll stage as short as the next day. Because especially it might be counterintuitive, and we used to do this differently. We used to stage a week, apart.
Yes.
But we found that in our older patients, that as long as they're hemodynamically stable, if we get them mobilized faster, they do better. And if you stage them a week out, like they don't eat for a few days, then they eat a little bit, and then they're basically not eating again. But if you just try to get it all done, like one day, next day, then they can stand up, they can eat. And actually, our practice has totally changed. So we try to do them in as short order as possible now, get them done, and then feed them and get them mobilized.
It makes sense. It makes sense. Thank you.
We have extra 5 questions, Christopher. And I wanted to ask a questions for rigid kyphosis, cervical kyphotic deformity. Sometimes we avoid to make C7 PSO because we wonder about instrumentation failure, and we made multi-level Ponte osteotomy for posterior, for example, for chin chest syndrome and head drop syndrome, and then anterior cervical discectomy and plate. And sometimes we add lumbar PSO for getting extra lordosis for global SVA. But you showed to us very good cases. You made C7 pedicle subtraction osteotomy. How do you select these patients? What are your strategy when doing C7 pedicle subtraction osteotomy?
Well, yeah, great question. As I mentioned in the talk, we try to avoid it when we can. So we assess the patients very carefully for mobility, not just on FlexX, but on planned stress where they're supine, trying to watch them over time to see if they relax. We look at the CT to see whether there's bridging bone, whether they're fused, or whether it's just a little osteophyte that we think we can break open with a posterior column osteotomy only. So we try to avoid it when we can. I definitely don't want people to leave the talk thinking we're saying, do a PSO in everybody. Definitely not. We try to avoid it when at all possible. And sometimes a posterior column osteotomy strategy, like you mentioned, is the best way to go if the patient is not totally rigid. And filling them in from the front or doing combined strategies also works great. We just found in our older population, from my data, they had more medical complications if we went anteriorly. So for us, if they're semi-rigid, we do posterior column osteotomy and pedicle screws. If they're rigid, meaning that they're fused, they're not moving, or we need a very significant translational correction, not just lordosis restoration, but a translational correction. Usually that means a C7 or T1, T2, T3 PSO, because that's where you're going to get the head moving back. You usually don't get a lot of posterior head movement if they're rigid at C7, T1, T2 without doing a 3-column in my experience.
Thank you. Thank you. And there is some question from Mohammed Zuhair. Thanks, Chris. Do you need to go up for cervical junction to get more lordosis in some cases, and what the risk?
Go across the cervical thoracic junction? Was that the question? Sorry, I was...
Craniocervical junction to get...
Oh, craniocervical junction. Yeah, yes. And I'll tell you that the most difficult case, and probably you guys have seen this, is the patient with long-standing sagittal imbalance who has a torticollis. Because that patient, if they have a torticollis and you correct them sagittally and you stop at C2, for example, those patients often still have rotational deformity from the muscle. So you can do preoperative Botox and traction to try to stretch that out. But in patients with long-standing severe torticollis type deformities, we're going up to at least C1 and sometimes occiput for those cases. Or if the patients really have compromised bone, or any issue like, for example, some of the patients that have long-standing sagittal deformity have pseudotumor at C1, C2 because of their hyperlordotic compensation. Those are the patients we consider going higher, C1 or occiput sometimes. Committing them to the occiput dose is difficult because usually these are very long procedures, and swallowing and being able to look down and all that can be much more difficult. So we try to stop at C1 if we can, but I would say to this day, my most difficult patients to get realigned are the patients with sagittal deformity and torticollis.
Yes, Yasirta asked, what about post-operative neurological complications? Post-operative.
What kind of complication?
Yes, complications.
Complications. Complications in general. Well, do you have another 2 hours? The complications are significant, and the most common.
The question is for neurologic complications.
Neurological, yes. So yes, the incidence of neurological complication is about 20% or so, especially if we stop at, or if we're doing a major 3-column osteotomy at C7 or T1. To a lesser extent, we see things like C5 palsy or sometimes iatrogenic foraminal stenosis. The most significant aspect in my mind with neurological complication and cervical deformity is really 2 things. Number 1, avoid C7 or T1 PSO or 3-column when you can. If you place your osteotomies lower, you take a risk from around 20% and make it about 5% of intrinsic hand weakness if you move to T2, T3, T4. So that's most important. The other big problem is that we use neuromonitoring in every case. In just about every case of our C8 palsies, they were all neuromonitoring negative. So they don't seem to show up on neuromonitoring. So that's why now we just try to avoid it. So you'll definitely decrease your risk of neurological complication by avoiding C7 and T1. Also, the other one is C5, C5 palsy. For that, very important to dig out the superior facet if you're doing a type 2 osteotomy. And the other thing we've done that has had an impact in our practice is doing some interbody fusion occasionally when we're really going to close them down in the back, to try to build up the disc height in the front to make sure we don't close them down too much in the back, in the vertical compression of the foramen.
Andre asked you a question, but you answered this question. I think, why do you prefer posterior osteotomies instead of only anterior osteotomy with resection of inclinatus? Yeah. For
low-grade flexible deformity, the anterior procedures work better. So I didn't go over a lot of very flexible deformities today, but if the deformity is very flexible, don't get me wrong, we go anteriorly, and we published a paper on that showing definitely superior results with flexible deformities going anteriorly. However, For semi-rigid deformity, that's where, in our experience, the patients do better with an all posterior approach with pedicle screws rather than an anterior posterior approach. Basically, if you can get by with only an anterior, that's great. But if you're going to have to go combined, then that's where we prefer to try to go all posterior.
Thank you. Ahmet Fawad Pirzat, yes, you answered neurological complication. Nicholas, thanks to you. Saad, thanks to you. Sigmund, yes, Sigmund, thank you for excellent presentation. Do you think all artificial intelligence will be playing an important role in the planning of cervical spine osteotomies in the future?
Yes, in two ways, for sure. And thanks for the question. You know my research interest. So in terms of predicting reciprocal change, that's where I think we'll see the earliest impact is in machine learning. Once we have several thousand cases, we'll be able to use machine learning to predict what's going to go on in the unfused segments, both occiput to C2, as well as T5 or T10 and below. So that'll have a major impact. Also in predicting outcomes and complications, like we published with the European Spine Study Group. The unfortunate thing is we now have 3,500 patients in the combined data set for ISSG, ESSG for thoracolumbar, but we're only at 300 patients total in our cervical deformity database. And European Spine Study Group does not have a cervical deformity database that we can combine with. So we don't have enough patients to predict accurately outcome and complications yet. That's why you haven't seen predictive modeling AI papers coming out on cervical yet. But we will see them for sure in predicting reciprocal change is probably the next thing you'll see.
Thanks to all of the audience. Chris needs to go to the surgery and we have a lot of questions, and we will complete this presentation, this webinar. And thanks all of the audience. Dr. Mehmezadeh, do you want to say something and for closing this webinar?
Yeah. I really appreciate all the speakers. This was a very nice meeting. I wish the participants enjoyed that. I must tell that I will publish the recordings in YouTube in 1 or 2 weeks. And there are some questions about that.
Thank you.
Thank you. Thank you for coming to all the speakers and all the participants.
Thank you very much.
Thank you.
Thanks,
Bye-bye.
guys. Great to
Thank
see you guys.
Good to see you.
Take care.
Bye.
Bye-bye.